Hello friends, welcome to Ashish Kale Educational Group. Myself Dr. Ashish Kale from Pune. This is the procedure where we are showing the ureterolysis. If you can see, the ureterolysis is an important procedure in advanced endoscopic procedures like endometriosis or maybe where there is a previous operative. You need to understand the retroperitoneal approach of ureterolysis. The ureter do have its own sheath that is called as a ureteric sheath, and if you do a parallel movements you can able to achieve the ureter which is under vision. You can see I am just doing the cutting of the ureteric sheath and the ureter is going to get visualized. This is the popular technique that wherein you need to understand you should be always a parallel to the tubular structures. If you are parallel to the tubular structures, usually the bleeding won't occur because the ureteric sheath now the ureter is visualized. You can see there is a different architecture of the microvascular capillaries which supply the ureter, and this is the adhesions of the peritoneum. This procedure we are showing it to all of you that how to do a ureterolysis when the ureter is puckered in the peritoneum and you need to do a dissection. You can hold the ureter and just you can do a dissection in the parallel ways. If you are doing it in a parallel ways, the sub sheath area, that is avascular spaces, try to open up it, and this opening will cause a more and more dissection in further down. This is the only three ports what we used in our institute, and we are used to this. This is the one on the lateral side of the both and one in the central port. We use a bipolar and bipolar sharer for the dissection, and sometimes we use a harmonic where we need that this is the appropriate instrument to do it. The instrumentation doesn't make any difference when this particular dissection is been done. If you are thinking the ureter is not visualized in a apex, you can just do a dissection and you can just take hold of this vascular planes. These are the microcapillaries. It is always advisable to just do a first is a dissect more and then coagulate and use activation of the any energy source in order to prevent the damage to the ureter. Usually, the color of the ureter will show it to you the integrity of the vascular supply or the movements of the ureter, which will be helpful. Some of the time, the people thought that when we are using the stent, it is a easier way to do a ureterolysis. But in our institute, we never do a ureteric stent prior to the dissection because using the ureteric stent make it more less pliable for the dissection, and your dissections becomes very difficult. You can see we are just going a parallel to the tubular structures, and this is always a dictum. You need to be a parallel to the tubular structures and not a perpendicular. If you are parallel to the tubular structures, it is appropriate that you will be doing this dissection without causing any harm to the vital structures. If like that, you can see the ureter has a endometriosis. When it is an endometriosis case like this, usually the endometriosis of the ureter is two type. It is intrinsic and extrinsic. The extrinsic endometriosis causes the puckering of the ureter from all the sides, and it causes the narrowing of the lumen, and once you do a dissection, the hydroureter or the ureteric pathology is going to get dissolved. But if it is an intrinsic pathology wherein the endometriosis starts from within, like a bladder endometriosis, you need to do a resection of the ureters and the new anastomosis with the bladder. This is the procedure wherein we are showing you that how the ureterolysis can be done, and this is the peritoneum which is puckered. We are going to do a peritonectomy in this patient. These are the educational videos, so that's why we are coming up with a different series that need to tell it to you how the things can be done in a particular case. You can just see if there are the two things which needs to be assigned, what is the course of the ureter has to be marked out, and then you can do a peritonectomy. The similar procedures can be done on the opposite side. You can see there is another thing that this is called as a pararectal spaces. You need to dissect it out the pararectal space. Once the pararectal space is dissected out, for the first thing that you can do just to do a walk-in, that if I am doing the same procedures of just to do a pararectal dissection, this pararectal space dissection cause again the mobilization of the ureter from the one part that is called as a your uterosacral. So this uterosacral dissection is helpful when you are doing this particular pararectal dissection, because this uterosacral is going to get much more evident when you are doing a pararectal dissection first. In this case, you can see there is a adhesions of the bowel also. So we are going to do a dissection of this pararectal space in order to dissect out the bladder from the center. You can see the bowel is adherent at the back of the uterus. The rectum is totally adherent. We are not going to see any of the spaces out here. So it is prudent that when you are doing this kind of a dissection in this particular plane, it is going to get a more and more. Now you can see my another arm is going into the tunnel and causing the safeguarding of the ureter, and the another dissector is going to do a dissection in the pararectal spaces, and this is a procured space. You can see the all the rectum is going to get adherent. There is called as always a pivot joint. This is the fat. Always you need to understand that the fat belongs to the vital structures. So if you are away from the fat, you are not going to get damaged to that particular structures in that particular dissection. You can see there is always a pivot joint wherein the rectum is going to get adherent, and I am now going to take, this is called as a little bit judicious cut. You have to cut on this particular parametrium and get the dissection of the rectum done. The same ureterolysis, because this is the video of ureterolysis, we are going to show it to you the ureterolysis on the right side. And if you can see, you can use just a needle holder and the bipolar sharer. If you are going to this is the sheath, and if the ureter is not going to get dissected out, you can just do a nicking of the ureteric sheath. You will come one plane above and start dissecting it out down, and this procedure will be helpful for you for dissecting of this particular disease and going to do a peritonectomy later on. You can see this is the puckered peritoneum which has been documented here in this case, and we are going to go deeper down, and we are going to do as I always talked, it should be parallel to the vital structure. So if I am doing a parallel dissection, my dissection will be very smooth. I'm going to hold the needle holder in a way that this particular space is going to get opened, and you can see there are the puckering strands, and if I'm going to do a dissect, I'm just going and giving the traction. You can see whole the parametrium is moving with that traction, and the ureter is puckered there. So once this dissection is been carried out one by one, millimeter by millimeter, you will and are going to understand that these are the fibers which is fibrosed out there, and this is the parametrial disease of the endometriosis. And once the parametrial disease is been cleared out, this patient usually, if having the good AMH and good fertility outcome after the surgical excision of the endometriosis. You can see again I am going a parallel in this particular way, and you can see this is the way where you need to be a parallel to the ureter and not perpendicular to the ureter. So this is the parallel dissection which is going on, and you can see this is the puckered peritoneum. Now I am going to take care of this puckered peritoneum, going to take care of the ureter. Ureter is always under the vision. So in our institute we never use a stenting, as I previously mentioned also, and this will be helpful when you are going to do this kind of a dissection in a longer run. So you can see the ureter is just below my sharer, and I am just giving the cuts. I am dissecting out. I am dissection is in the peritoneum, which is only affected. The one thing is you need to understand the ureter has the fork, that the lower fork is the uterine vein, and the above is the uterine artery. You can see this is the uterine artery which is going through. So it is if you are not very keen about dissection, this usually bleed in this particular state, and you will have torrential bleeding. So there is called as a water under the breach. This breach is made by the uterine artery, but now we come to know with the event of the 3D camera system and the robotic that there is a deep uterine vein which goes below the ureter, and this usually bleeds in a radical hysterectomy or the endometriotic approach. So this is the where we do a dissection of the ureter. You can see the ureter which is kinked now. This is the uterine artery. So that's why we just coagulated the uterine artery. And I know being a fertility preservation surgery, but if you are just coagulating this uterine artery doesn't have any impact on the fertility for that matter. This has been documented for multiple times, because if I wish to take this endometriotic nodule out, I need to dissect in that particular pathology, and that's usually sometimes has a uterine artery has to get sacrificed. Now I reached the tunnel, and this is called as ureteric tunnel, and the ureteric tunnel dissection has been completed. Again, you can see there is a toe